Hi, everyone. Welcome to the LactFact podcast, which highlights recent clinically relevant research, policy statements, and protocols that you, as a practicing lactation professional, would probably like to know about. I'm your host, Dr. Eglash. I'm a board-certified family physician and breastfeeding and lactation medicine specialist at the University of Wisconsin School of Medicine and Public Health. This podcast is written and produced by the nonprofit organization IABLE, which is the Institute for the Advancement of Breastfeeding and Lactation Education. We have no commercial funders for this podcast series. Hey everyone! In my last LactFact podcast, I discussed guidelines from the American College of Radiology on breast imaging during lactation. This month, I'm going to review the guidelines from the American Society for Breast Surgeons on the management of infectious and inflammatory breast lesions. The first author is Dr. Katrina Mitchell, who's also a breastfeeding medicine specialist. The guidelines were published in JAMA Surgery on April 1st, 2026, and the guidelines cover lesions for both lactating and non-lactating individuals, and I'm only going to discuss breast lesions during lactation, specifically lactational mastitis and granulomatous mastitis. So let's dive in, and first I'm going to talk about lactational mastitis, which they state is not including mastitis during pregnancy, since that's a totally different situation. The authors state that when evaluating mastitis during lactation, one would need to first determine if the mastitis is infectious or not. They state that the difference between infectious and non-infectious mastitis is the presence of cellulitis or deep organ space infection, and that fever does not necessarily imply infection. I'm going to make some comments during this podcast that are off the guidelines specifically. So my guideline here is that it can be really hard to determine whether mastitis is infectious, and we don't have an easy way of determining this. So back to the guidelines. If lactational mastitis is assumed to be inflammatory and not infectious, the first steps include conservative management, which would be ice and avoiding excessive removal of milk so that milk production is not driven up. Anti-inflammatory medications and acetaminophen can be used just for pain relief. And I want to emphasize that anti-inflammatory medications like ibuprofen are not specifically recommended in this protocol to treat the inflammation itself. Massage of the breast should be strictly avoided, as this seems to predispose to more tissue injury, leading to infection, phlegmon, and abscess. The guidelines suggest that infectious mastitis should be suspected if the patient has been performing massage, using heat, and or pumping excessively. If symptoms are worsening after 24 to 48 hours despite conservative measures, it would be reasonable to start antibiotics. They recommend dicloxacillin 500 milligrams 4 times a day as the first-line treatment, and then for broader treatment, using cephalexin 500 milligrams 4 times a day. For those with a penicillin allergy or who have methicillin-resistant Staph aureus, clindamycin 300 milligrams 4 times a day would be reasonable. TMP sulfa double strength can also be used twice a day, but they caution on the use of sulfa if the infant is premature because of the risk of hyperbilirubinemia, and to avoid it in mothers with G6PD deficiency. There was strong consensus among the authors that an ultrasound should be performed for patients with infectious lactational mastitis who have a mass, or for patients with infectious lactational mastitis with cellulitis who are not improving despite treatment. Also, they recommend mammography if the symptoms are not responding to treatment to rule out a malignancy, or if the patient qualifies for age-appropriate screening anyway. The guidelines then go on to discuss percutaneous interventions for fluid collections during lactational mastitis. There was consensus among the authors that aspiration and culture can be attempted for fluid collections less than 3 centimeters, but serial aspirations are not recommended. So what I mean is that using a syringe with a needle to remove fluid would be reasonable as a first attempt for abscesses that are less than 3 centimeters, but if it's larger, it's not recommended. For fluid collections that are more than 3 centimeters, it's recommended to do a stab incision using an 11 blade with drain placement assuming that that first aspiration fails. And even though they're saying not to do a first aspiration, I think we all know that logistically we end up doing a first aspiration to diagnose the fact that it is an abscess and then go from there in terms of management. In which case, if it's more than 3 centimeters, the recommendation would be to do the stab incision. And the reason for this is that serial aspirations fail because the fluid is super thick and it's just not easily drained by a needle. Also, a lot of these abscesses have walls in them, so they're loculated, and it's going to be hard to get the fluid out of the different spaces within the abscess using a needle. When using a drain, suction should not be added because this will stimulate more milk production and create a new avenue for milk removal. A culture should be done of the fluid removed, and then the drain is usually able to be removed after 3 to 5 days. After the drain is removed, it's pretty normal for milk to leak from the area where the drain was placed, and this will gradually resolve. But it's important to tell patients not to squeeze the breast to encourage milk to come through the drainage site because this will increase the likelihood that drainage will continue in that region. And with proper management, just conservative management, leaving that area alone, there's less than a 2% risk of persistent milk fistula. And after about a week, that milk drainage will go away. They specifically mention that it's fine to breastfeed after using lidocaine for the incision and drainage procedure because the amount of lidocaine in breast milk has been found to be negligible. In cases where the fluid collection is really thick and heavily loculated, meaning that even if there's a stab incision, only part of the abscess can be drained, then these people should go to surgery, go to the operating room under anesthesia to have that area cleaned out. So now I'm going to transition to their guidelines on granulomatous mastitis. Other than reporting that the incidence of granulomatous mastitis is 0.37%, the authors don't go into epidemiology, histology, or the genetics of granulomatous mastitis because this guideline is really all about management. Granulomatous mastitis most often presents with a palpable mass with redness and often fluid collection. So it can look like mastitis with abscess. Although it's not mentioned in the guideline, I have to add that these lesions are so much more painful than the typical mastitis with abscess. Also, granulomatous lesions differ because they tend to cause these tracts or fistulas to the skin with spontaneous drainage. And this is not something that you see with the typical infectious or inflammatory mastitis where the fluid collection is walled off, such as an abscess. There are a few subtypes of granulomatous mastitis. So specific granulomatous mastitis is a subtype associated with an underlying granulomatous disease, such as tuberculosis, actinomycosis, brucellosis, histoplasmosis, and sarcoidosis. Another subtype is called cystic neutrophilic granulomatous mastitis, which is considered a granulomatous response to cyanobacterium. The biopsy of these lesions have specific findings, including cystic spaces and or lipid vacuoles rimmed by neutrophils and epithelioid histiocytes. The lipid vacuoles can contain the cyanobacterium because they're lipophilic, and in these cases, doxycycline is recommended. If there's no underlying disease and the culture of fluid and biopsy are negative for cystic neutrophilic changes, then the granulomatous mastitis is considered idiopathic and antibiotics don't play a role. So these patients usually undergo an ultrasound and mammogram, and the guidelines discuss the typical findings on imaging, which I won't go through. They state that an MRI can give a more accurate picture of the extent of disease than a mammogram or ultrasound. In terms of definitive diagnosis of granulomatous mastitis, a core needle biopsy should be performed, specifically to exclude malignancy and to evaluate for the typical histologic findings consistent with granulomatous mastitis, meaning it's nice to have a biopsy that shows that this truly is granulomatous mastitis. That said, sometimes the biopsy is negative, and if the clinical picture is consistent with granulomatous mastitis, then proceeding with treatment is recommended. In terms of non-surgical treatment, very mild cases of granulomatous mastitis can be treated with oral anti-inflammatories such as ibuprofen or Celebrex. If there are moderate symptoms, Intralesional steroids would be the first intervention. The steroid is injected both into the cavity of the lesions and around the outside of the inflamed region, like the walls of the inflamed area where there's fluid collections. They mentioned using a 40 milligram per ml triamcinolone solution mixed with 1 or 2% lidocaine. I would personally add, outside of the guidelines, that depending on the size of the lesion, I've usually injected somewhere between 40 and 80 milligrams. And this seems to be quite effective for local treatment. For severe or refractory granulomatous mastitis, they may need repeat intralesional steroids. They don't state in the guideline how often these should be given. And from my experience, injections every 3 to 4 weeks are pretty reasonable. In other words, after one injection, there's continued improvement over the course of about 3 to 4 weeks, and then it kind of stabilizes. And at that point, it would be reasonable to do another injection. We don't know if there should be a limit as to the number of injections. Going back to the guidelines, in cases of moderate disease, they also mention the addition of immunosuppressant agents and even possibly oral steroids. If immunosuppressant agents are needed, then they recommended referral to rheumatology. There is some evidence that people have responded to prednisone starting at 60 milligrams with a 4 to 6 month taper, although for many patients, other immunosuppressants are preferred during lactation, such as aethioprine or sulfasalazine. From my experience, I usually refer to rheumatology for immunosuppressants if I find the need to do more than one intralesional steroid treatment. So that's it. That's what's in the guidelines. So I'm hoping that these guidelines will provide support for surgeons and other physicians who have not had much education regarding the management of infectious or inflammatory lesions during lactation, or who don't see these cases very often. It's likely that lactation consultants in various regions around the country will be seeing these patients, and these guidelines can be shared with their local physicians whom they are referring to for evaluation and management. Hey everyone, thanks for listening. I encourage you to check out iAble at lacted.org, which is LACTED.org, to learn more about our educational projects, courses, educational handouts, videos, live conferences, and webinars. By becoming a member, you are not only supporting our free projects, but you will also receive a series of benefits which you can learn about at our website. I'll be back with another LactFact in a few weeks.